measurement of each one of the waves. So in the P wave abnormalities, we saw how to diagnose atrial enlargement, and in QRS abnormalities, we saw how to diagnose ventricular enlargement. Anyway, we will go in detail about the importance, the criteria, how to diagnose, what are the various types of ventricular enlargement, what is the clinical importance, and so on. So first we look at the atrial enlargements. So before that we must know, although the ECG is one of the investigations to diagnose chamber enlargement, the best investigation to diagnose chamber enlargement is echocardiography. So echocardiography is the best investigation if you want to diagnose atrial enlargement, ventricular hypertrophy, or any chamber enlargement. But nevertheless, ECG gives you a very simple investigation which gives you a clue or which makes you suspect there may be a ventricular enlargement and make you feel that you need to do an echocardiography. So in that way, especially when you are in an official hospital or some basic hospital where you have only electrocardiogram will give a clue about the presence or the absence of chamber enlargement. So the ECG criteria have got low sensitivity and high specificity. So by which we mean that if the ECG criteria of a particular chamber enlargement is there, most often the chamber enlargement is there. That's what we mean by high specificity. When we mean by low specificity means the normal ECG does not rule out chamber enlargement. You understand that? So high specificity means when particular criteria for a ventricular enlargement is present, 90% of times ventricular enlargement is present. When ECG shows LVH, the LVH is there in 90% of times. That's what it tells you, it's high specificity. But normal ECG does not rule out LVH. That's what it tells you, the low sensitivity. So that's what we mean by high sensitivity and low sensitivity and high specificity. So the ECG becomes a poor man's test to suspect a ventricular enlargement. So everything based on this principle again, we saw that this again when we went in for the electrical axis. So depolarization coming towards the lead will record a positive complex. If it is atrial depolarization, it will record a positive P wave. If it is a ventricular depolarization, it will record a positive QRS complex. If the depolarization is going away or the vector is going away from a particular lead, that lead will record a negative complex. If it is a P wave, atrial vector is going away, P wave will be negative. If the ventricular vector is going away, the QRS will be negative. So this is what we have to understand first. So before going in for any chamber enlargement, it's very, very important that you have to look at the standardization and speed. Don't jump to press rate of 43 per minute without looking at the speed. So for chamber enlargement, whatever the criteria we are going to tell is going to be correct only when the ECG is recorded in 1 millivolt standardization, which is 10 millimeter in height. 1 millivolt standardization, which is 10 millimeter in height. So all the criteria I am going to tell is going to be valid, and the duration is going to be valid only when the ECG is recorded at 25 millimeter per second speed. So this slide we have already seen. Anyway, we'll recapitulate the normal atrial depolarization. So for the atrial enlargement, you have to look at the two leads which are L2 and V1. In L2, both your right atrial and left atrial depolarizations are going to come down. They are going to go inferiorly. So in L2, both the right atrial and left atrial depolarization will be positive. Initial point of the P wave represent right atrial depolarization.